Yeah. Hello.
Okay.
Sorry.
So let's
Yeah.
start. Yeah. Sorry.
No, sorry. Just hold on. Just hold on. The president of the society will have some welcome remarks.
Oh
So
yeah.
Dr.
Okay.
Olfa,
Okay. Sorry.
the moderator,
Yeah.
will
Yeah.
introduce.
Please go ahead. Go ahead. Yeah.
Thank you so much. Thank you.
Yeah, I thought we'll just go ahead. Thank you, Dr. Olfa, for coming, for accepting to talk to us. And we hope that this will be the last time. We'll have more of you talking to us at this webinar series to run bi-monthly. I want to welcome everyone to this platform. It's very important for us to use every opportunity that we have to learn on how to create better outcomes for our patients. So, Dr. Olfa, we're very grateful to have you. I will know that learn a great deal of things from the discussion we have tonight. Thank you. Over to you, and let's start.
Thank you so much.
Good morning, all. Good morning, Prof. Good morning, Prof. Olfa. Good morning, Mr. President and the Secretary, and all in attendance. Today we have a critical session on the cornerstone of sepsis management, which is fluid management in septic shock. I am Dr. Mohammed Usman. This topic is filled with both established dogma and emerging evidence. And we are incredibly fortunate to have Professor Olfa Hamzaoui. And she's a professor of medical ICU. She's board certified, a specialist in intensive care since 2006. She has also board certification in echocardiography, hemodynamics, and in mechanical ventilation. Her areas of research and expertise are cardiovascular monitoring, echocardiography, assessment of volume status, use of vasopressors in critically ill patients, gender inequality in critical care membership in professional societies.
Hi. Do you hear me? I don't hear anyone for the moment.
Yes, we can't hear him.
No.
Can I be heard now? Hello? Can I be
Dr.
heard
Usman,
now?
we didn't hear you. I think the end of your nice introduction, we didn't hear.
Oh, I am very sorry. It was a network glitch.
No problem.
But I'm back now.
Yeah.
Okay. I think I was just trying to say that you have Professor Olfa has several publications. She has about 79 articles in PubMed, and she has had about 120 invitations on conference invitations. She positions held. She is a past chair of the National Congress of the French Society of Intensive Care and the current French national representative in the Council of the European Society of Intensive Care Medicine. She is also the co-director of the hemodynamic workshops and the active member of the cardiovascular section of the European Society of Intensive Care Medicine. She has other activities, such as she's the associate editor in Journal of Critical Care, associate editor of Annals of Intensive Care, associate editor of for Journal of Intensive Medicine. This is just to mention a few. We are happy and incredibly fortunate to have you today.
Thank you.
So I hope we would all learn and then pay attention to Prof. Olfa's presentation. Prof, I think you can start.
Okay. Thank you so much. Thank you for all these nice, warm, and very, very elegant introduction. Really
Prof,
very happy.
You can start, Ma.
I'm very happy to be among you this morning, this evening, sorry. And as I said, I'm really very proud to be with the Nigerian Society. Anyway, this is my mother continent. I'm originally from Tunisia, North Africa, so we belong to the same continent, and I'm proud of it. Okay, so today my talk will be around fluids and how can we manage fluid during septic shock. First of all, I want to start with to disclose my conflicts of interest, and here are them. So I chose, in order to talk about this topic, to begin and to probably see with a clinical case and at the bedside, how can we manage the fluids during septic shock. And I chose this clinical case of Mr. Z, a male, 35 years old, with no medical history. He has just a very recent history of abdominal pain since 5 days, diarrhea and vomiting, asthenia and fever. And he has also presented very recently a shortness of breath. And this is why he presented to the emergency department. And so when he presented to the emergency department, here are some of his parameters, hemodynamic parameters, and some of the tissue perfusion parameters. He had a prolonged capillary fill time. He was hypotensive with 53 millimeters of mercury of mean arterial pressure. As you see, tachycardic. The oxygen saturation was a little bit low, and he had a real polypnea, as he has a 35 of respiratory rate. So my first question will be, what will be your immediate treatment for this patient? Of course, as you see, there is fever, he's tachycardic, there is a history of probably abdominal pain, but also shortness of breath. It looks like sepsis, what we are dealing with. So if we want to say what are the immediate treatment in this case, of course, a bolus fluid is obviously one of the first treatment that you should give for a patient who's hypotensive with a low mean arterial pressure, but not only, probably also after making blood samples, infectious and all the infectious, I would say, laboratory exams, we will give also antibiotic. So this is, I would say, the first question, but it's the easiest one. The second question I would ask, what type of fluids will you probably begin? Do you begin crystalloids, starches, albumin, or other? And this is also probably not so complicated, but we can, of course, we'll have some time probably to discuss this. I would say crystalloids. And this is for sepsis, the type of fluid I would choose. Why? We know now in the Surviving Sepsis campaign, the recommendation of the Surviving Sepsis campaign is to use crystalloids as a first fluid for resuscitation. Probably balanced, which is, as you say, as you see, a weak suggestion because we don't have solid data about the superiority of the balanced regarding the crystalloids. And the albumin actually is not recommended, but probably only if you have a large amount of fluids. And I would say, for the moment, in my unit, we don't use any albumin solution. But what is, I think, important that the recommendation are against using gelatin for resuscitation. So I would say crystalloids probably balanced for the hemodynamic resuscitation at the initial phase. I would say the third question is probably the most interesting one when I would ask how much fluids will you give to your patient? And I just gave some proposals, 500 milliliters, 1000 milliliters, or 30 ml per kg, or none of these. I let you just a few seconds concentrate about it. I know we cannot be interactive for this question, and we will have probably some discussion after. But I will probably surprise you if I say none of these. I would choose none of these, despite the recent recommendation of the Surviving Sepsis Campaign, is that we probably need to give at least 30 ml per kg for the first 3 hours. But I'm not sure that this, it's not a recommendation anyway, it is a weak suggestion. And I'm not sure that it is really a very logical. And I will, in the few coming slides, explain to you why none of all these proposals, even not the 30 ml per kg, is a good proposal for the patient and anyway for septic shock. Why? Because when you look at the recommendation of the Survival Sepsis Campaign and you read the rationale of this recommendation, the reference that comes up in the paragraph where there is the rationale, it is about a retrospective cohort that reported that there was a superiority in mortality for the patients who received 30 ml per kg compared to patients who received other amounts of lower amounts of fluids. So this is as the recommendations, and as probably you know that the recommendations normally are based on solid data and more importantly randomized trial, and there was no randomized trial that showed that there is a superiority of this 30 ml per kg. So there is no evidence-based, as you say, for this recommendation. So what they say in the Surviving Sepsis Campaign, the experts, if there is no evidence, they will prefer the best practice. But I don't see where is the best practice for this recommendation. I will explain why. Why? Because actually, if you have a patient, for example, presenting with pneumonia, the patient with pneumonia, he has or she has a relative hypovolemia and mainly also an increased capillary leak because of the inflammation of the lung. So what happens at that time? You will have a patient who actually with, as you see here, this is from physiology, if you give an amount, the same amount of fluid for a patient without inflammation, lung inflammation, without an increased capillary leak when they have pneumonia, you give the same amount of this and you give the same amount for a patient with like a pneumonia and an increased capillary leak, you will induce pulmonary edema very quickly. And of course, as you have more inflammation, you will have more leak in the capillary permeability, and you will have a higher risk of course, an increased extravascular lung water and increased pulmonary edema. So this is the first situation for a patient who's presenting with pneumonia. Of course, in a patient who will be presenting with an abdominal sepsis, peritonitis, we know that there is an absolute severe hypovolemia. So even the 30 ml per kg, I would say, probably it's not sufficient, and we need to give more. So you see, these two types of sepsis it cannot be managed for the fluids the same way because, of course, of physiology. The second element also, which is important, two patients with different cardiac function cannot also be managed the same way for the fluid resuscitation. Why? This is also based on physiology and cardiovascular physiology. This is the Frank-Starling curve of a patient with a failing heart, and I will just show you also a Frank-Starling curve of a patient with a normal heart. And as you see, there is a steep part in the normal curve of the Frank-Starling curve, where when you increase ventricular preload, for example, by giving a fluid bolus, you will increase the stroke volume with an important, significant increase in stroke volume. And this is what we look for. This is a patient with a normal heart. But if you look at the patient with a failing heart, when you give a fluid bolus, you want very quickly you will arrive to the flat part of the curve. So if you increase ventricular preload by giving a fluid challenge, you won't increase significantly stroke volume. So you are not beneficial for the cardiac output for the patient, and at the same time you will increase the end diastolic left ventricular pressures, and so induce pulmonary edema. So a patient with a cardiac dysfunction compared to a patient with no cardiac dysfunction cannot also be managed with the same volume of fluid. So the 30 ml per kg is just something nonsense for these two main reasons. And this is why with some experts like Jean-Louis Vincent, Daniel De Backer, we wrote this editorial just after the Surviving Sepsis campaign came up. And we just make an alarm about the recommendation of the fluid management. And we said that we need to recommend to individualize initial fluid resuscitation, even the first bolus that you give. No single formula can be applied to all the patients, as fluid requirements will vary substantially depending on the source of sepsis. As I said, pneumonia is different from abdominal sepsis, and of course, pre-existing cardiovascular function. We don't give the same amount of fluid for a patient with a cardiac dysfunction, like a patient with no cardiac dysfunction. So, and this is why also we wrote a few years ago with Mathieu Zviak, Jean-Louis Teboul, Xavier Monet, just a position paper about our vision, how to individualize this first bolus. First of all, you need to infuse probably a small ball, like a 10 ml per kg crystalloids within the first hour. You cannot wait for 3 hours and giving the 30 ml kg. First of all, a small bolus for all of the patients. And of course, you need to reassess. You reassess very quickly and just after your first bolus. And of course, if the patient is still hypovolemic because there are signs of fluid losses, there is an abdominal sepsis, there is a mottling and increased capillary fill time, so you increase your effusion rate. But if the patient, he doesn't have a profound hypovolemia and he just is presenting with even a worsening of tachypnea, a fall in oxygen saturation, you need to stop in the 10 ml kg for crystalloids. So this is important. Individualize even the initial fluid therapy during sepsis is important. Okay, so let's go now to our case. And the patient actually he had a CT scan, and we made the test for the coronavirus, and he has an RT-PCR, a SARS-CoV-2 positive. And as you see, he was just gave 30 ml per kg of fluids and antibiotic therapy, but oxygen saturation was dropping and oxygen requirement was increasing, and he had a high oxygen needs during in the emergency department. But still, as you see, hypotensive with a mean arterial pressure 55 millimeters of mercury. So what should we do in this case? Should we give more fluids because he had profound hypovolemia, he had diarrhea, vomiting for 5 days, fever? Or should we start now norepinephrine? Or, I don't know, probably dobutamine, or nothing else, and we wait and see? I'm sure I will let you just a few seconds think about it, but I'm sure, of course, we cannot let the patient with the 55 millimeters of mercury and tachycardic, as he's still in shock. So we need to do anyway something. The butamine, not sure, because the patient is in sepsis. We know that the butamine you need if you have a real cardiac dysfunction. It's not a cardiogenic shock. I would say, of course, we need to make echocardiography, but it seems as we didn't just manage the patient correctly as a septic shock patient, we cannot introduce the butamine. Fluids or norepinephrine. I'm a little bit afraid about fluids, and this is what we discussed just before in the slide. The patient has not probably, but he has a SARS-CoV-2 positive, so he has a COVID pneumonia, and so he has an increased permeability of the lung capillaries. So he has a high risk of pulmonary edema, and this is what happened. He just dropped his oxygen saturation, and he increased his oxygen needs. So it is really like a stop signal, an alarm to say, oh, even if he needs more fluids, not sure that the fluids will go to the vessels, probably they will go to the lungs, and probably will worsen his respiratory rate. So I won't say fluids, I would say norepinephrine, and also not only because there is, of course, the risk of pulmonary edema, but there is also, it went very quickly. But there is also one signal that you should look at when you have this kind of patients. Look at the diastolic arterial pressure. It is very low, 40 millimeters of mercury for a young man, or even for an old one, because the old one normally has a higher even diastolic arterial pressure. It means that the patient has probably a low vasomotor tone, and he needs a vasoconstrictor and not just maintaining fluids. Why? Because this is physiology. Diastolic arterial pressure is determined by the vasomotor tone, and it reflects vasomotor tone. Low diastolic arterial pressure means that the patient had a low vasomotor tone. This has been nicely illustrated in this study from the Bicêtre Hospital that just compared in 67 ICU patients the different parameters of blood pressure and the peripheral resistance. What they found is that the peripheral resistance was significantly associated to the diastolic arterial pressure, which was not the case for the systolic, for example, arterial pressure, or even the pulse pressure. And this is the first important information. The second information about the diastolic arterial pressure is that, as you know also from physiology, that it is the left ventricular coronary perfusion pressure. So if you let the patient with a low diastolic arterial pressure, you may, of course, make the patient face a high risk of low perfusion pressure of his left ventricular coronary, and of course induce even an acute myocardial infarction. And so the diastolic arterial pressure will trigger for the introduction of vasopressors. And so at this moment, we managed the first bolus. We even gave probably more than what's needed, but we need to stop here giving fluids. We need to say that the patient has a vasoplegia. The treatment for vasoplegia, it is norepinephrine and not fluids. And even because there are also some debate about the timing of this introduction of norepinephrine. Should we, even if the patient's still hypovolemic, should we introduce it early? I would say yes. We have a lot of arguments now in favor of the early introduction of norepinephrine. Because the first argument is that it prevents prolonged severe hypotension. As we know, septic shock is characterized by a depressed arterial tone, and fluids alone cannot correct severe hypotension. The second argument is that it increases cardiac output. It increases cardiac output by two main mechanisms. The first mechanism is that norepinephrine will increase preload due to an increase in stressed blood volume. And this is what we explored a few years ago in Bicêtre Hospital when I was resident in 2010. We had a background, a rational, physiological rationale, and coming from the pharmacological characteristic of norepinephrine. Norepinephrine is an alpha-1 agonist agent. It may increase preload by increased the stressed volume, as you see, because it acts on the arterioles, but also on the venous system. So it will induce a venoconstriction. And as you see, if you induce this venoconstriction without giving fluid, you will increase the stressed volume and you will increase preload and increase cardiac output if your patient is hypovolemic and preload dependent. So this is what we found in this paper. 100 septic shock patients, they already received but a small amount of fluids, around 1 liter, and we look at the effect of increasing norepinephrine in these patients. By increasing mean arterial pressure, we observed a significant increase in cardiac output and an increase in what we call the global end diastolic volume index, which was displayed by this device, which is the transpulmonary thermodilution device. It is an indicator of preload. That means that preload increased in these patients, and more interestingly, preload dependency, pulse pressure variation decreased. So this is what we concluded, that the early administration of norepinephrine in severe hypotensive septic shock is able to increase cardiac output through an increase in cardiac preload. And what does it mean? This means that norepinephrine increases a preload, decreases the degree of preload dependency exactly like fluids, but without giving fluid. And so redistributing the non-stressed volume into stressed volume. So in these kind of patients, you will of course, manage them with a win-win strategy, because you will increase fluids as they are probably still hypovolemic, but you will also protect them from the real excessive real fluid that you will give. And of course, there are also other arguments in favor of this strategy to introduce norepinephrine. It increases cardiac output by another mechanism. It increases cardiac contractility. This is also what we showed in this paper. The rationale is coming also from the pharmacological characteristic of norepinephrine. Norepinephrine is also a beta-1 agonist agent, not only an alpha-1. So it acts on the myocardial contraction. And this is what we try to test in this population of septic shock patients that were resuscitated at the early phase of septic shock. We they were all hypotensive at the inclusion, and then we increased norepinephrine, or we introduced norepinephrine, we restored mean arterial pressure, and we repeated the transthoracic echocardiography before and after correction of mean arterial pressure by increasing norepinephrine. What we found is that the left ventricular ejection fraction improved, the velocity time integral of subaortic flow, which is a surrogate of stroke volume and cardiac output, also increased significantly, but not only the left ventricular parameters, but also the right ventricular parameters improved, like the S-prom and the TAPC. And this is despite the increase of left ventricular afterload, because we, of course, constructed the arteries, we increased mean arterial pressure, we increased systolic arterial pressure, so we increased the afterload of the left ventricle. But despite this, we improved contractility of the heart. And this also, even in patients who had a moderately deteriorated contractility function. And in this subgroup of patients where they have at baseline left ventricular ejection fraction lower than 45%, they increased their left ventricular ejection fraction with norepinephrine by restoring mean arterial pressure. What are the potential mechanisms? The first is probably the effect on myocardial beta-1 receptors with a real direct effect, because they are not downregulated at the early phase of sepsis. The second mechanism is probably because we increased blood pressure, we increased the mean, the diastolic and the systolic, the diastolic arterial pressure, so the coronary perfusion benefited from this increase, and so improved cardiac contractility. And interestingly, when you give norepinephrine, you will also prevent your fluid overload. You will improve your strategy of fluids. And if you prevent fluid overload, of course, you will improve the outcome of your patients. Why? Because we know that overload is associated to the harm of your patients. And this has been nicely also demonstrated in this paper, which was a retrospective analysis of two cohorts, the Andromeda trial and a cohort from Colombia, with a paper from Gustavo Spenatascon and Glenn Hernandez. They found that in the group where they introduced very early norepinephrine, compared to the delayed norepinephrine, there were less fluids in the very early group. So we go back to our patient. So we introduced norepinephrine. He had an amount of 3 liters of fluids. He was under 0.3 microgram per kg per minute of norepinephrine. This is not a base dilution, but it is the tartrate dilution, the European one. And so, yeah, he arrived in the ICU, but he still has hypotension with a low mean arterial pressure, as it was of 63 millimeters of mercury. So now the question, what should I do? Should we give more fluids? Should we increase norepinephrine? Should we give dobutamine? Or should we assess preload responsiveness before this? Let you just a few seconds to think about it, and then of course we can discuss after. But I would say more fluids, I'm not sure. The patient arrived in the ICU. He has always still oxygen, high needs of oxygen. His oxygen saturation is not good. He has a high permeability of the lung capillaries, so there is a high risk of increasing pulmonary edema. I'm not sure that I can give more fluids anyway, blindly, I would say. An increase in norepinephrine, but if you look at your blood pressure, the diastolic arterial pressure is no more low. So probably there is no mainly vasoplagic mechanism. And so not sure that the patient need to increase more his vasomotor tone. Dobutamine Of course, if there is no cardiogenic shock, I would check with my echocardiography, of course, and I already checked, and I need to check the cardiac contractility of the patient and the participation of a heart failure, for example, but the patient, he has no heart failure. I would say at that moment, probably he's still hypovolemic. He has the risk of pulmonary edema. If I'm just thinking about giving fluids, I want, first of all, to assess what we call preload responsiveness. That I mean that I test if the patient will respond to my fluid challenge before giving the real fluid challenge. And this is what are the recommendation of the Surviving Sepsis campaign when there were the COVID patients at that moment. We need to have a conservative, probably over liberal. I would say we need probably to manage more your fluids. If shock persists, you need to test preload responsiveness because there is, of course, high incidence of ARDS in case of COVID pneumonia. So why do we need to detect fluid responsiveness? Because not all the patients are fluid responsive. This is what we know from literature. This is a meta-analysis published in 2002 by Frédéric Michard and Jean-Louis Teboul that found that when you give fluids to your patients, only only, I would say 52 were responsive, but 48% of your patients where you gave the fluid challenge were fluid unresponsive. That means they didn't increase their stroke volume, their cardiac output. You gave the fluids without any benefit. And of course, with the harm of a risk of fluid overload. Why? This is also physiology. I showed you just before also this Frank-Starling curve that it is the relationship between the ventricular preload and stroke volume. We know that when the patient in the steep part of this curve, you increase ventricular preload, you increase stroke volume, but if you arrive to this flat part of the curve, of the Frank-Starling curve, even if you increase preload, you won't increase stroke volume, and the patient is called preload unresponsive. So probably the problem here is to identify if your patient is in the preload responsiveness part of his curve or not. This is the problem. But is it easy to have it without any test? I'm not sure. Why? Because we don't have only one curve of a patient. We have a family of curves going from a failing heart to the normal heart. So a patient who has only one parameter, for example, a static one, let us take, for example, CVP. If you have only one value of CVP, for example, of 7, a patient with a good Frank-Starling curve, a good heart, good systolic function, probably at CVP 7, he is still preload responsive. But in a patient with a failing heart, this CVP, this ventricular preload value, may be in the flat part of the Frank-Starling curve, so that the patient is no more preload responsive. So this is why static measures of preload like CVP or even the wedge pressure or parameters of echocardiography like the E over E prime or the left ventricular end diastolic area or even the IVC diameter cannot reliably predict the responsiveness of to fluids. And there is also another reason why we need to detect this fluid responsiveness, because fluid responsiveness is a dynamic phenomenon. Yeah, you can check it now, but 2 hours after your patient, that doesn't mean that he's still preload unresponsive or preload responsive. He may change his status. So this is what was also reported in the Andromeda trial published in 2019. At age 0, there was 70% of the patients who were preload responders, compared to 30%. At age 2, we had 28% of responders, 15% of responders at age 4, 13% at age 6, and 4% at age 8. This is the dynamic evolution of the status of preload responsiveness. So we need to check it, but we need to repeat the tests in order to see if our patient is preload responsive. And also we need to check, as I said to you, fluid overload is harmful. So we cannot give a fluid challenge if the patient is not fluid responsive, because you won't increase the stroke volume and you will cause harm. And we have a lot of data. This is one of the data that was published, the SOAP study by Jean-Louis Vincent in 2006, that reported that the cumulative fluid balance, the positive fluid balance during sepsis, is an independent factor associated with mortality. So you cannot give a drop of fluid without evaluating before giving it that it is beneficial for the patient. The fifth reason is that there are also some data that when you use these tests of fluid to evaluate fluid responsiveness is associated with improved outcome. We have some data. This is a national multicenter prospective cohort coming from Argentina that examined the association between the use of the dynamic tests of fluid responsiveness and outcome, and they found that the dynamic tests for fluid responsiveness were also an independent factor of survival for this cohort of the national cohort from Argentina. There is also this meta-analysis that also reported that the strategy of resuscitation based on dynamic assessment of fluid responsiveness decreased mortality. And now we have recommendation from the European Society, from also the Surviving Sepsis Campaign. We suggest to use the dynamic measures to guide fluid resuscitation over the static parameters. And the new recommendation from the European Society of Intensive Care regarding the management of fluids in these patients, this is also what was suggested. Administering up to 30, that means that probably the maximal is 30 ml, but anyway, you need to adjust and to individualize based on the clinical context, the frequent reassessment. This is what we said. You need to choose to administer different volume of crystalloid based on their clinical judgment, individual patient characteristic, cardiovascular comorbidities. This is what we said. And probably mainly to use and to assess preload responsiveness before administering more crystalloids in these patients. So very quickly, what are the dynamic measures? What are these tests? And as I don't have enough time because it's still long to go into details in the test, but we can, of course, discuss this afterwards. There are two big families, actually, of these dynamic parameters. There are what we call the heart-lung interaction-based parameters. These are parameters that are induced from the heart-lung interaction and the mechanical ventilation. Why and how is it? Mechanical ventilation actually can, of course, induce the cyclic changes in preload. And so, of course, in stroke volume in cases of biventricular preload responsiveness. And so, as we know that stroke volume and pulse pressure are correlated, and there is, as there is no changes in aortic compliance over the respiratory cycle, the changes in pulse pressure, the pulse pressure variation, what we call, will reflect the changes in stroke volume variation. This is actually a schematic representation of what I'm saying. This is mechanical insufflation. At inspiration, what will happen? We will have a decrease in the right ventricular filling. You will have a decrease in right ventricular stroke volume. And of course, this will decrease the right ventricle, an increase in the right ventricular filling, an increase in the right ventricular stroke volume. And of course, this happens if the right ventricle is in the steep part of the Frank-Starling curve. This is at inspiration, but of course, between the right ventricle and the left ventricle, we have what we call the pulmonary transit time, which is actually a 2-3 heart beats later that will fall at expiration. What we will have a fall in left ventricular stroke volume at expiration, and so we'll have this variation of pulse pressure variation, because we will have a decrease in stroke volume and a decrease in pulse pressure. At insufflation, what we have, insufflation, a decrease in venous return, a decrease in the stroke volume of the right ventricle, a decrease in the left ventricle, and then a decrease in pulse pressure at expiration. It begins at inspiration, and it is seen in the monitor, in your monitor of pulse pressure at expiration. This is what we call pulse pressure variation. We have a second family, which is based on maneuvers like the passive leg raising. This is the passive leg raising, which actually is based on a transfer of blood from the legs and the abdominal compartments to the intrathoracic compartment. It mimics fluid challenge, but it's not fluid challenge because it is transient. As you put the patient back to the initial position, this fluid transfer will be cancelled. So, and the hemodynamic response to this passive leg raising will have a real increase in cardiac output if the patient is preload responsive, should predict preload responsiveness. And this is something also which is easy to do. And it has been widely explored with a lot of data. We have even meta-analysis that shows that the increase in cardiac output during PLR is a real way to assess preload responsiveness, wherever the way you use, the method you use to measure cardiac output. That means you can measure cardiac output during PLR with echocardiography, for example. You make echocardiography at the baseline, and then during passive leg raising, at 1 minute of passive leg raising, if the patient increases his cardiac output by more than 12%, that means that the patient is preload responsive. That means that the patient, if he is in shock, he may benefit from a fluid bolus. And this is also what we wrote in this editorial. We recommend to individualize fluid therapy using this, what we call the dynamic challenges. This also was written and suggested by the Surviving Sepsis campaign, and even include a response to passive leg raising to when you try to assess preload responsiveness. So we go back to our patient, and the patient is in the ICU. 2 hours later, as you see, actually he has an ARDS. He's ventilated with a PEEP of 14, FiO2 of 100, and he has only 89 saturation. So he has a real ARDS in addition to the septic shock. So at this time, we need to assess preload responsiveness, but not only, we need to actually assess the benefit risk from further fluids. The patient is probably preload responsive, but should I give fluids in this patient? And for this situation, it is probably more advanced. We can probably introduce a more advanced devices like the transpulmonary thermodilution and the amount of pulmonary edema, which is actually given by the extravascular lung water, may give you an idea about the amount of pulmonary edema and the risk of the increase of the pulmonary edema in this case. And so we have a cutoff values of 10 ml per kg. If you have a value that is increasing after giving fluid, that means that the patient has a higher risk of pulmonary edema, and probably the risk is more important than the benefit of increasing stroke volume, and probably I won't give fluids, but I will increase norepinephrine at this time. There is also a simple way to see. If the patient, as you see, a PF ratio which is very low, with a high FiO2, I don't have a lot of, I would say, a lot of range of manipulation for the oxygenation. So I would, even with a PF ratio, at that moment, I would stop giving fluids, even if he's still preload responsive, and probably increase norepinephrine at that time. There are, with this transpulmonary thermodilution, we may have what I said, the extravascular lung water, that is, when it is higher than 10 ml per kg, it can accurately detect the presence of the damage of the lungs. And there are some data that show that when you follow the fluid balance with extravascular lung water, you have less cumulative fluid balance than when you follow it, for example, with supervising and monitoring the wedge pressure, the POP. And also you have a lower ICU days, lower mechanical ventilation days. We have even some data regarding the survival, and a high value of extravascular lung water in this meta-analysis is significantly associated with mortality. We have another parameter in these transpulmonary thermodilution devices associated to the extravascular lung water, which is the pulmonary vascular the permeability vascular pulmonary index, which is actually it evaluates the degree of the capillary leak. What I showed you just before in the first slides of my presentation, a PVPI of 2, the patient doesn't have a high capillary permeability leak, but if you have a PVPI higher, that means that you have a high and increased lung capillary permeability, and so he is of higher risk of pulmonary edema. And of course, PVPI of 6 is have a more even higher risk of pulmonary edema. And so this is what was validated in this first study by the team of Pisetro, where they found a cutoff value of this PVPI of 3. That means that, yes, this PVPI is also an independent predictor of mortality in RDS, probably associating the amount of pulmonary edema, the high risk of capillary permeability leakage. This association will give you the higher risk of the patient of developing pulmonary edema. So the patient presenting with septic shock, I would say, with this, if he has also ARDS, probably we may choose on between restrictive strategy or a liberal strategy. Probably it is one way to do it easier. And this is what was tested in big trials, like the classic trial published in 2022, restrictive trial in patients with septic shock compared to a liberal strategy. What they found there was no difference on survival if you make a restrictive fluid strategy or a standard fluid strategy. Another study, which is the Clover study, that also compared a very restrictive strategy with a very early norepinephrine versus liberal strategy. The first strategy, you give norepinephrine first as a treatment for hypotension. The liberal strategy, you give fluids as a treatment for hypotension. And in the first arm, fluids as a rescue treatment. The second arm, norepinephrine as a rescue treatment. And what they found is that there was no difference between for all the outcome criteria between these two strategies. And so this may give us or make us ask ourselves, so actually why we don't have this positive effect for these patients? Because I think it's a simple way. How can we blindly randomize patients without estimating the individual need of fluids? Some patients who need more fluids will be, for example, in the wrong conservative strategy and will have an increased risk of mortality. And other patients will need less fluids, will be, for example, in the wrong liberal strategy and will have increased risk of mortality. So we cannot actually, of course, use these trials to say wherever strategy we may use, there is a neutral effect and we are free to use whatever. No, we need this. These, for me, these two papers just emphasize on the fact that we need to individualize for each patient and not to say that for this patient we need to make a restrictive, or for this one we need to make a liberal. We need to individualize patient by patient. And so if I sum up the strategy for the management of patients in septic shock, I would say a first bolus, individualize your first bolus, give a small amount of fluids. Of course, you reassess very quickly. You may increase this amount if the patient has a profound hypovolemia. You decrease if the patient have a cardiac dysfunction, and consider early use of norepinephrine if you have a low DAP. This will give you, of course, an effect like fluids, but also it will make you have less fluid resuscitation and, of course, less risk of fluid overload. After this, if shock persists, consider tests, dynamic indicators of preload responsiveness. Do not give blindly fluids for the patients. But of course, in the more complicated situation, especially when the patient is with the ARDS, you need to always balance your risk and benefit for giving your fluids. Wherever the criteria you can use, if you have advanced monitoring, why not? But if you don't have, the respiratory status of the patient may help you to just assess this balance, this benefit-risk ratio for your patient. Thank you so much. Merci beaucoup.
Yeah, thank you very much, Prof. Olfa, for the wonderful presentation.
Thank you.
I think it was very informative, and I really followed it and I enjoyed it and I have learned a lot. So I think it will be the same for a lot of people on the platform. I will encourage people to please ask questions so that if there is anywhere we can further clarify, and then in order to further understand this wonderful presentation. I think while we wait for any of the questions, my own one of the questions I would like to put forward is while considering the use of vasopressors, at what point in time do we consider adding another vasopressor to, like, norepinephrine, in case the hypotension still persists despite all these maneuvers? Which one will be the most favored? And I think, maybe you can help us answer that, ma.
So just to be sure that I well understood your question, when we need to consider a second vasopressor or the use of the introduction of norepinephrine.
Yes, to consider a second vasopressor.
A second vasopressor. Okay, so second vasopressor more than norepinephrine. Actually, the recommendation is for in the surviving sepsis campaign, which is a weak recommendation because we don't have also solid data about survival of this. It is the introduction of vasopressin. And I would say first, before considering to move on to a second vasopressor, check if your patient is preload responsive. Check if your patient has or not a cardiac dysfunction. And check if your infection source is very well controlled. These are the three things you need to check before you're saying, I need a second vasopressor. A second vasopressor may be the vasopressin, for example. This is what is suggested now by the Surviving Sepsis Campaign. And what is also suggested that you cannot wait for high doses of norepinephrine. You need probably to give it when the doses are moderate of norepinephrine, between 0.25 and 0.5 of norepinephrine base. This is the dilution of the norepinephrine. I'm emphasizing about this because, for example, in France and in Europe, we don't have the same dilution as the US. We have a dilution which is the tartrate dilution of norepinephrine, so it is 2 times the doses of the US colleagues. So, for example, when you read the Surviving Sepsis Campaign, it is written that you need to probably suggest to add vasopressin if the patient is between 0.25 and 0.5 microgram per kilogram per minute of norepinephrine. But for us, if we translate it to our dilution of norepinephrine, it will be between 0.5 and 1 microgram per kilogram per minute. But it's still not too clear because we don't have, as I said, a real positive data about survival, about the kidney function. We have a pathophysiological rationale about adding a second vasopressor that is still under, of course, debate. This is what are the recommendations. And of course, the recommendation, and we have now data also about it, do not give it when it is refractory. When you have a multi-organ failure, higher doses of norepinephrine doesn't work. You don't need to give a second vasopressor, it doesn't work. So you give it, if you give it with a moderate doses of norepinephrine.
Thank you, Prof, for the clarification. Let me just start with some of the questions on the platform. There is a question, and the first one I can see here is, thank you for the presentation. What
Excuse me, Dr. Usman.
Yes, sir.
Please.
Yeah.
Professor Bakinde Oshinake wants.
I don't hear you.
We couldn't hear you, please.
Professor Oshinake not done. Let's allow him to speak.
Professor Oshinake.
Oh, sorry. I didn't. Prof, you have the floor, sir.
Yeah, okay.
Okay. Thank you. I hope you can hear me.
Yeah.
We can hear you.
Okay. Thank you, Olfa, for that brilliant presentation. Reminds me of the presentation at the workshop we had like 2 years ago. You were there. Thank you so much. Now, one or two comments. I appreciate the fact that one is to be careful with fluid. And so when you say stop fluid, I don't think you are trying to give an impression that that patient will be totally off fluid. because I know we still want to have maintenance fluid. I want you to clarify that. Okay?
Yeah, of course, yeah.
Then the other issue is about the the fluid itself, the crystalloid. There are issues with what we have here. Essentially, we have normal saline, we have a ringer's lactate. So I want you to make comment on what do you think could be challenges with any of these two fluids, because these are just the crystalloid we have around here. Okay. Then you also mentioned in your own facility, you don't use albumin at all. Are you ruling out albumin completely in the care of this patient? Okay, so I want you to make comment about that. Okay,
Yeah.
not too much time because there are so many questions. The final one, the two studies you talked about that did not find any difference between the the liberal and the restrictive group. You are giving us some reasons why you don't think those two studies actually we should guide them. But don't you think it's important for us to actually consider, maybe other centers or other studies that we can actually select this patient appropriately? I don't know if your own center too, maybe from your center, do you have published data on this your own practice, whether it does improve outcome in this patient or not, so that we have something we can fall back.
Please switch off your microphones, please.
Please
Switch off your microphones. Oh.
Please mute your microphones, please.
Dr. Jedon, can you mute, please, these people?
Please mute your microphone. If you are not talking, mute your microphone, please.
So those two, is it possible we have, or maybe from your own center, other centers, any of these studies that can actually show us that when we are restrictive, the outcome is better? Because I don't have any other one except these two you have mentioned. Thank you very much. Well done.
Thank you. Thank you. Thank you for your excellent points, and they are all excellent. I would say for the fluids, the maintenance fluid, I'm talking about stopping fluids when the patient has a high risk of fluid overload, when he has a high risk of pulmonary edema. You stop giving fluids even if he's still preload responsive. That means even if he's still hypovolemic. The maintenance fluid, you need to, of course, also be careful about it. You need to restrict if your patient in a situation of fluid overload with also pulmonary edema, high risk of pulmonary edema, you need also to pay attention to the maintenance fluids, and you need to restrict them as much as you can. This is also, we have a lot of data coming from Manuel Malbran and others that show that even the maintenance fluid may harm the patient. So this is one point. The second point about crystalloids that you use, saline and ringer lactate, they are the crystalloids that also we use. They are the salines the crystalloid that we use. So you may use them wherever you want. What we say that probably you need to alternate between the saline and the ringer lactate, because as you know, large amounts of saline may also be harmful for the patient. So if you have a large amount of fluids to give, do not give all saline. Mix with the ringer lactate. The ringer lactate is more balanced, and it may be probably sometimes more beneficial for some patients. We don't give albumin, because there is no, for the moment, data for septic shock patients to give albumin, even when they have a high capillary permeability, whatever we want, because even if there is a pathophysiological rationale, all the clinical data is negative, and it is very costly. So it is not really reasonable to give albumin. About the studies that are negative, I think because yes, we need to target the good population. We need to have an individualized algorithm in order to include the patients and not to just randomize patient blindly. As I said, you will be in the restrictive and you will be in the liberal. It's not like this. It is, of course, because of even some patients will need more than others. Some, as I said, because of the sepsis, because of the cardiovascular function, because of all these parameters. So you need to have an individualized. For the moment, we don't have any data that are positive for the restrictive strategy because I think we didn't include the targeted population. We have data coming from the Andromeda trial that will be published probably in October by the European Society Congress. The Andromeda 2 is coming up. So by the end of October, it is about the resuscitation, the early resuscitation of septic shock, and it uses a real individualized algorithm. And of course, we don't have for the moment, I would say it is confidential, the results. I'm among the investigators, but we will see if an individualized strategy will be beneficial or not for a patient, and not it is a real individualized strategy. I hope I just I responded to all your questions. Probably I forgot one of them, but I'm not sure. There is Osman, sorry, there is one question that is really important here in the chat, and I think for the limited resources countries, can we determine when to commence norepinephrine and we use the non-invasive blood pressure? I would say yes, even though it's not the more precise one, because the diastolic, when the patient are, of course, very hypotensive, sometimes the non-invasive are not very precise. But if you have a low diastolic arterial pressure and the low mean arterial pressure, the mean is correct in the non-invasive. So, of course, you may use it. Yeah.
Thank you very much, Prof, for the answers to the questions so far. Let me go. There's another question on the platform. Let me quickly look at it. So when using SLR to assess fluid responsiveness,
passive leg raising, yeah, PLR.
Yeah, it's passive leg raising, though it's not SLR. How frequently is it done in an ICU patient?
The test. When if you are asking yourself if the patient needs or not a fluid bolus after the early phase of septic shock. I'm not talking about the early phase. The patient is just arriving, he has sepsis. You don't think about this. You give your first fluid bolus. Sometimes you may give even a second fluid bolus, and then after, if he's vasoplegic, you give norepinephrine, and this is without any parameter. After this early phase, you need probably to have to use the tests and to use dynamic tests like the passive leg raising test, for example, in order to assess preload responsiveness. So when you ask yourself if your patient needs a fluid bolus, you need to test it with a dynamic parameter like passive leg raising or other parameters. So I cannot give a frequency. I would say when you ask yourself.
Sorry, please mute yourself, please. Please mute. Okay. Thank you, Ma, for the response to the questions. There's another question on the platform. He said, can we use urine output to test fluid responders in septic shock patients?
Can we use what? I didn't
Urine
hear.
output.
A
Urine
urine
output. Yeah.
Oh, no, the problem of the urine output is that it takes time, you know, to see. It takes, I would say, at least 1 hour to see if the patient is responding or not. The problem is that it's not, urine output is the last thing that you may see. If the patient, I would say it is an evaluation of your renal perfusion, but it cannot use it as a test for preload responsiveness. And if, for example, sometimes there are some people that give a fluid bolus and look at the urine output if it is if it increased or not. But this is not the right way, because anyway, you gave your fluid bolus, so it is non-reversible fluid challenge, and urine output is not always correlated with your stroke volume. Your Mr. Peter Kubili, please mute your microphone, because we cannot hear anyone. Sorry. Thank you. So I would say not. No, we cannot use it.
Okay. Thank you for the response, ma. There's another one here. It says, can adrenaline be a substitute to noradrenaline in case of non-availability?
Of course. Yeah, of course. Of course. If you don't have a norepinephrine, anyway, we don't have a choice. So you give adrenaline, of course.
Okay. Then there's another question here on ultrasound measurement of inferior vena cava collapsibility index. Can it serve as a predictor of fluid responsiveness in septic shock patients?
Yeah, actually, in spontaneously breathing patients, it's not reliable at all. So you cannot use it when the patient is spontaneously breathing. You can probably use it when the patient is mechanically ventilated. And I say probably because we have data just reporting that it's not that excellent, but it can be used. When the patient is under mechanical ventilation, well sedated, you may use it. When the patient is spontaneously breathing, it's not a good parameter to use.
Okay, and then there is another question here on the role of dobutamine and vasopressin.
Dobutamine is an inotrope, so it is a beta-1, beta-2. We use it when we have a real cardiogenic shock and a real heart failure, which may happen, of course, when the patient has sepsis, because we have what we call a septic cardiomyopathy and a real heart failure. So there is a place to give dobutamine at that moment, but you need, of course, first of all, to identify these patients. You cannot give dobutamine blindly anyway, because it may be very harmful for the patients. Because it is a vasodilator, it gives the tachycardia. So if you don't have a heart failure, a low cardiac output, the patient with a low tissue perfusion, you don't give dobutamine. Vasopressin is a second vasopressor that we can use. It's not a catecholamine. It is a hormone. It uses another receptor on the vessel, and so it may be a good alternative. Of course, in addition to norepinephrine, if the patient has a profound vasoplasia. But of course, do not forget to give, if your patient, you are increasing your doses of norepinephrine, do not forget to give your corticosteroids, even a glucocorticoid, some steroids, because the steroids improves the affinity between the catecholamine and the receptor on the vessel, and of course it will enhance the vasoconstrictive effect of the catecholamine. So if your patient is not responding, give steroids before asking yourself for vasopressin.
Thank you, Ma, for all the beautiful responses. I think we can. I think maybe I should just take one more question before we call it a day. I see one. So what? There's a thing here. There's a question here. It says, which type of echo can be used as a dynamic measure? Is looking at either transthoracic or transesophageal or both.
No, transthoracic. Transthoracic echocardiography, you can use it with only the velocity time integral of the subaortic flow, which is a surrogate of stroke volume, during passive leg raising maneuver. It's a good way to assess preload responsiveness, even in the patient's spontaneously breathing.
Okay, thank you very much, Prof. Olfa.
Thank you.
I think we can call it a, but we need a vote of thanks from Dr. Ojedonyi, sorry. You give just a few minutes, just vote of thanks. Please, are you there, Dr. Ojedonyi?
Yes, I'm here. Good evening.
Okay. Can you give us a vote of thanks, please, sir?
On behalf of the I-CCSN president, Dr. Joe Botokwa, and all the ESCO, we want to really appreciate you for this wonderful presentation. You've actually enlightened us, and you've actually also helped us to bring down some of these management of the patient's youth management, because as has been explained earlier, some of the advanced equipment you have access to, we might not have access to them here. So you actually have been able to bring down to the level where we can practice. We appreciate you for this. Thank you very much.
Thank you so much. Thank you. It was really a good it's a good occasion for me, opportunity to meet you, and I'm really very happy, of course, to meet all the Nigerian colleagues here.
All of you who will be having us. Also, we want to specially invite you to our next year annual general meeting that will be coming up. We'll be looking forward to seeing you there. Thank you very much once again.
Thank you so much. Thank you. And appreciate your invitation. Hope to see you soon. Thank you.
Can we have okay, hello, Prof. I was thinking we should just have a few minutes for the president's remark.
Yeah.
Just a few minutes for the president's remark. Mr. President, sir.
Thank you very much. Thank you, Prof. Thank you for the detailed lecture. You can see we had over 170 persons in attendance. That tells you how important the lecture is to our parties here. And then I want to implore you to also consider the fact that we would like to have some lectures on applied physiology and applied respiratory physiology and cardiovascular physiology to critical care management. You know, like both of the things you mentioned are basically derived from applied cardiovascular and respiratory physiology, which I think are the basis of what we practice in critical care. I think we should consider it to colleagues. We have some sections for it, and then we would like once in a while to discuss the physiology behind our practice. And that will be very useful to all of us back home here. Thank you very much. Like our PRO said, we invite you to Abuja. We'll send you a formal letter with your colleagues, as many as of African descent that you can bring to talk to us. We shall put our minds together, to see how we can improve the outcome of the critically ill patients in our communities. Thank you very much. Thank you, everyone. Thank you, the immediate past president from Chineke, and very respected colleagues who have joined. Dr. Elumelu and the rest. I couldn't even remember the names. Thank you very much. Good night. See you guys next time. Bye.
Thank you.
Thanks, everyone. Thank you, Prof. Goodbye, everyone. Bye.
Thank you, Irene, for the invitation. Thank you. Bye. Bye.
Yeah, bye-bye, everybody. God bless you all.